Tiwari. I am going to speak on SICS versus FECO in this instruction course on defining SICS. We all are doing SICS, and now it's a question of refining SICS so that we can take up the FECO tomorrow very conveniently and the learning curve becomes smooth. That is the idea of this session, this instruction course. But at the outset, I think I must compare the SICS and FECO and give an insight into how important it is to learn and master it and master the SICS. So this is about comparison of the FECO and SICS on technical scale and on the technical grounds. Both the techniques have their own consumers, their merits and demerits. Decidedly, the socio-economic factors do have an important bearing on the treatment or the technique that we adopt in a given situation. For example, the Lucentis, which is approved by US FDA for the purpose of the intravitreal use, is being replaced by Avastin, which is although an off-label drug and much economical, but it is the Avastin that is being used worldwide for the purpose of the anti-VEGF injection being by intravitreal. Similarly, SICS is a poor cousin of the costly of FECO, but it is as acceptable as FECO if put in the right perspective. Friends, Charles Kelvin, who gave us FECO way back in 68, 69, but it was lying in our OT cupboard for nearly 20 years. It was only after Michael Mayferland, who gave us sutureless group, that we started doing our SICS. We started doing FECO investigation. So it was not the FECO that revolutionized the concept. It was the sutureless wound that revolutionized the whole concept of the cataract surgery. And remember that for implantation of a rigid IOL after FECO, you need to construct a similar wound, which subsequent speakers will be talking about. If you look at the journey of the FECO emulsification, it started with sclerocorneal rigid lens, where you need to construct a self-sealing wound that you are going to learn from subsequent speakers. This was followed by corneal incision, foldable lens, bifocal, multifocal, unifocal, toric, bimanual, accommodative IOL, and so on. But the fact remains that more than 85% of the patients after the FECO emulsification, even today, they wear spectacles. And rest do not despite their are effective. And in other words, the spectacle-free terminus after the FECO emulsification has not yet reached. Let's now compare the FECO and SICS. We can compare on these three grounds: that is unaided visual acuity, surgically induced astigmatism, and endophysial cataract. If you look at the unaided visual acuity, the different studies they showed that the FECO gives better uncorrected visual acuity at the end of 1 week and at the end of the 3 months also, in comparison with the SICS. That is true. In my own series of 600 cases, I observed that the uncorrected visual acuity following SICS is less as compared to the FECO. But the difference may be, let us say on average, 6.9 with the FECO and 6.18 in case of the SICS. If you look at the surgically induced astigmatism, that is what is going to mainly determine the uncorrected visual acuity. We find that FECO induces slightly less astigmatism in comparison to the SICS. That is true. But we should not forget the incisional burn that can occur following the FECO, and that may also contribute to the astigmatism, especially some kind of indicators. The endophysial cell damage, as reported in the different series, varies from 4 to 25% in SICS and 5% in FECO. But if you look at the ground reality, it is that we see more corneal hairs following FECO emulsification. If I operate on 10 FECOs, I will see corneal hairs in 1 or 2 cases. This may be because of the natural tendency to work close to the cornea to avoid when we do phago classification, especially a nova is 10 to 1 close to the cornea. And that is what is the most important factor that is going to produce corneal hairs following phago classification. The other factors that contribute to the corneal hairs in phago may be pre-op status of the cornea, hardness of the cataract, anterior depth, and of course the proficiency of the surgeon. You become more proficient, you produce less corneal hairs. That is also true. So the net difference at the end of the road is the degree of astigmatism. We understand that surgically induced astigmatism is 0.75 diameter less in phago. This difference is statistically significant. But is it clinically significant? Do we see patients having half diameter or 0.75 diameter astigmatism moving around? They are happy with 6 centimeters in that, no problems. So this is acceptable. Of course, those where the job demands better visual acuity, we can always go in for direction. On the other hand, phago classification has a relative risk of weakness drop. The reported incidence is 0.3 to 0.9% in different series. But that does not mean phago is a difficult surgery. As a matter of fact, except for the addition of the machine, it demands less surgical expertise than that required for doing a high quality assessment. It's just like driving a motorbike and driving a car. Driving a car, once you learn it, it is more comfortable, you have a very good control. So, it is not a difficult surgery once you learn it. Our SICS requires some expertise. And I must say that every SICS surgeon may not learn phago for the reasons peculiar to him or his workplace. Maybe a guy is working in a government setup, where the government is not going to provide consumables all the time. You need to change the phago stream. The consumables are not provided by the government, or he is aging, he is 65 years and he is happy and comfortable with the SICS. No problems. But I must say that every phago surgeon must learn SICS. This is just an example. This sister, she announced that the phago tip is broken. I said, give me another tip. I said, I want another tip. She said, the other tip has not been supplied. And I had to sort on to the SICS, which we will be talking about in detail. You can always fall back on the cushion of the SICS in situations like power failure or motion failure. So what we understand out of all that is that every phago surgeon must learn SICS. Power failure, motion failure can happen anytime. A 100% phago surgeon is neither true nor desirable. It is reported that even the most experienced phago surgeons, they need to convert in nearly 3.7% cases. And we should not force phago in situations such as corneal opacity, black cataract, broken CCC, overtake glaucoma, and sunlight. I must conclude by saying that SICS is not only an alternative to phago, but an additional technique in our armamentarium. Thank you, friends.